So thank you very much. My name is George Siege, and I'm a professor of epidemiology at the Harvard School of Public Health, as I mentioned before. And I want to put everybody, suspend animation, put everybody into a time machine and take everybody back of an outbreak, of how to work up and investigate an outbreak, and some of the social issues and some of the issues that came up in the early days of AIDS, which I think really had an impact on how the epidemic spread and also how our response to the epidemic was colored by folks who initially became infected and we became aware of in the United States. So as Dean Burke described, there's many simultaneous outbreaks that were occurring around the world with various clades and subtypes of HIV, all of which are important to understand and think about. I'm going to tell a story about AIDS in the US. At the time I started work at the health department in Boston and state of Massachusetts, I was responsible for setting up AIDS surveillance. I started in 1983. So a lot of the people and characters you're going to meet, I'm using clips from And the Band Played On because I think it's very illustrative of epidemiology in action. And also I want you to think about if you were in that small group of people at CDC or at the local health department working up an outbreak of what we now know was a brand new infectious disease, how would you go about thinking about this, thinking about the etiology, how would you design that first study, and then where we ended up many years later. Actually, it was only the course of the movie, the course of the clips are really only 3 years of time passes, but it was very important time. So in thinking about this, I want people to keep in mind is basic descriptive epidemiology that's in any epidemiology textbook. What is AIDS? Is AIDS a new disease? If it's a new disease, how does one develop a case definition? And how to define AIDS? And this was a controversial issue going back right in the beginning. And then how you would design an etiologic study to determine the cause of AIDS. And so as you think about this and you think about, watch the movie and so forth, the clips, think about these. These are sort of the fundamental questions that you'll see in Chapter 1 or Chapter 2 of any epidemiology text, and it's certainly any outbreak investigation. So in the spring of 1981, there was initially an outbreak of pneumocystis carinii pneumonia associated with immune dysfunction in 5 homosexual men in Los Angeles and New York City. And this was published in the Morbidity and Mortality Weekly Report. CDC at the time, and they still do, they publish these weekly reports that basically are based on reports coming from local health departments, and everything from measles to polio. Not that we have any polio anymore, but back in the day we did. Every infectious reportable disease in the country is all compiled in this Morbidity and Mortality Weekly Report. And every week we would get these reports and pore over them and look at where the outbreaks were occurring, especially measles at that time. So prior to this report, pneumocystis was seen exclusively in individuals with congenital cellular immune deficiencies, basically kids born without an immune system, or hematologic abnormalities, immune suppressed transplant patients. So patients who were transplanted, kidney transplants, stem cell transplants, that basically they were immunosuppressed because of the transplant, would get this opportunistic infection called pneumocystis carinii pneumonia. It was extremely rare in the United States before 1979, and CDC, luckily for CDC, they had, you had to send reports to CDC in order to, and enter your patient on a pneumocystis registry in order to get treatment for pneumocystis, which was aerosolized pentamidine at that time, or actually pentamidine, the drug pentamidine. So when CDC went back, they saw the incidence of this was very rare. Prior to 1979, there were no requests for drugs among people with no underlying reason for immunosuppression. And they did this because they were concerned about any kind of new outbreaks, new diseases that would cause immunosuppression in large populations. Those are the kinds of diseases that certainly put lots and lots of people at risk for all the bugs that we deal with every day in our lives with our phenomenal immune system, starting with our skin and mucosal immunity and both the humoral and functional immunity and cellular-based immunity, we do very, very well living in a very, very scary environment from the perspective of being exposed to bacteria and viruses. In fact, not only were we exposed to Ebola this morning, but all of us shaking hands and introducing ourselves to each other. Who knows what else we were exposed to, and hopefully we'll wash our hands and our skin is intact and we will not transmit something else that we don't even know about. That was a very pleasant, a Debbie Downer moment for everybody. So here's a slide of a induced sputum of pneumocystis pneumonia, and you can see the pneumocystis here, if I can get this to work, these little, and eventually develops into a full-blown pneumonia, and people really do die of this disease. It's a very aggressive pneumonia, and let's see, why is this not working? All right. So this is supposed to be changing the slides, right? We can do it the old-fashioned way. So I'm going to first show this clip from this initial clip from And the Band Played On. So put yourself back into 1981. For those that have not read the book is phenomenal. You will not put it down. And for those that have not seen the movie's phenomenal. It's got every character, good, bad, an all-star cast. It was a lot of fun to actually watch the movie and see the whole thing. So remember in 1980, the political environment, Ronald Reagan had just won the election. Big cuts occurred at CDC almost immediately thereafter. And this was really when the first cases were identified in the United States.
Thanks very much. Thank you.
We'll be back.
You know,
Doctor?
No.
here we are. This is...
When is his T-cell killed?
I gotta tell you, Dr. Gottlieb, this is weird, man.
What?
He doesn't have any.
How can he not have any T-cells?
Well, his immune system's gone.
It's way past his bedtime. But let me...
Morning. Good morning, Dr. Guinan.
Jim,
Yeah.
can I talk to you for a minute? I just got this in the mail from our man in L.A., Dr. Shindera, who got it from a Dr. Gottlieb. I think you ought to look at it right away. Jim, looks like there's a very weird epidemic breaking out among gay men in Los Angeles. There have been 5 cases of pneumocystis with no contributing disease within the past few months, and already 2 fatalities.
Hot stuff.
Mm-hmm. Plus, I made some phone calls to New York and San Francisco, and it seems that they've had similar cases. I think this ought to go into the weekly newsletter as soon as possible. What did you do that for?
I don't decide what goes in the newsletter. I can only recommend. But, Mary, we got a new administration. Do you want to see this published so that people can read it? Or do you want to see it killed?
Thanks.
So that was the initial report, and you can see right away that there was a political consideration. Jim Curran is now dean of the School of Public Health at Emory. Really sort of led the charge, and you'll see a number of other epidemiologists, a very, very small, tight group of people that were really put on to this particular outbreak, which the purpose of putting it in the MMWR is to alert clinicians, infectious disease docs, nurses around the country to be on the lookout for similar cases and start reporting similar cases. That's the network that we had in 1981. Okay, this is, so why am I not? No, we don't want to do that again. Okay, so the characteristics of the 5 cases all had concurrent other infections, all had cytomegalovirus infection. So maybe it's cytomegalovirus infection or a new variant of cytomegalovirus. All 5 were men who had sex with men. 2 out of 5 had frequent contacts, whatever that means in terms of frequent contacts. Does that mean one more contact than I? So it's very ill-defined in terms of what people meant by frequent contacts. 4 out of 5 had evidence of past hepatitis B infection. No common sexual contacts were reported. All 5 had reported use of nitrate inhalants, poppers. So maybe there's a drug-related etiology here. Maybe it's not a virus. Maybe it's not a sexually transmitted disease. 1 in 5 had reported intravenous drug use, and 3 of 5 had low numbers of T helper cells. In fact, those 3, they had no helper cells, no cellular immune response at all could be detected among those individuals. So then the next report, so this was sent out, and suddenly a month later, clinicians started sending in reports of not just pneumocystis, but another cancer, actually a sarcoma of cancer of the blood vessel lining, Kaposi's sarcoma. And there was 26 cases reported among men who have sex with men, 20 in New York City, 6 in California, and it was put in the MMWR on July 4th. So really, in a month later, this was reported. Kaposi's is normally seen among older men, over 60, of Mediterranean or Ashkenazi Jewish background. So it was very unusual to see this in young men. So again, the signals thinking about unusual sort of occurrences, putting the pieces together. And also, KS was very rare. So when people reviewed tumor registries in Connecticut and New York and Massachusetts, they found that for the period 1961 to 79, only 50 to 150 cases of Kaposi's per year. And since 79, the number of KS cases had risen dramatically. So within a month or two, there was a lot of information, people checking tumor registries, pentaminine request logs, starting to put together the pieces to figure out what's going on here. So here's a slide of Kaposi's. Again, it's a sarcoma of the blood vessel lining, and it forms these plaques. And here, there's Kaposi's on this individual's foot, heel. So the characteristics of the cases, the 26 cases with Kaposi's, again, all 26 were men who have sex with men. 7 of the 26 had serious infections after their Kaposi's diagnosis, so they had other infections. 6 had pneumonia, and 4 had biopsy-proven pneumocystis. So here was the connection from the initial MMWR piece that came out, clinicians looking at that. And again, 12 of 12 tested all had cytomegalovirus infections. So one of the early leading etiologic candidates was, could it be CMV infection or a new variant of cytomegalovirus? So I just wanted to sort of talk a little bit about the cast of characters you're going to meet in the next couple of clips. As I mentioned, Jim Kern is now Dean of School of Public Health at Emory. Mara Guinan was very instrumental. Harold Jaffe became, I guess, Dean at School of Public Health at Oxford, but now he's back at CDC. Dale Lawrence worked in the vaccine division at AIDS, Division of AIDS, for many, many years. Bill Dower was a sociologist who did many, many of the interviews and trained me to do interviews of people with AIDS early, and you'll see some of his interviewing techniques, and I wasn't quite as rough as Bill, but he was a very good mentor. And Don Francis, who is the book is really based on Don sort of reporting to Randy Schultz in a first-person narrative of sort of, this is the view according to Don Francis. Don went on to lead the vaccine effort at Genentech and then VaxGen, and was very instrumental in getting one of the first early envelope vaccines off the ground, and is quite a persuasive individual and pretty passionate individual at that. So let's see. Yes, this is Don. I can't seem to have. Play where?
Yeah, it looked like before.
Oh, yes, okay. Great. So this is Don Francis arriving at CDC.
Don, is that you? Hi.
Nice to see you.
How long has it been?
Smallpox in India.
Come on, join us.
Dale, how long do you plan on doing that?
Till I get my peanut butter cookies.
What? What? Hey! Yeah!
Guys, I'd like you to meet Don Francis.
Hi, just doing a little demonstration of the benefits of a sound knowledge of applied science. Hi, Harold Jaffe, sexually transmitted diseases.
Hi, Don. Bill Darrow, sociology. You didn't shake Harold's hand, did you?
Don, hi. Thanks for coming. Did you meet everybody?
Yeah.
How's Phoenix?
Warm.
Don't we have a meeting in my office at 3 o'clock? What's everybody doing here?
Trying to have lunch in 4 minutes like you.
If one of those is peanut butter cookies, that is mine.
Let's go.
Dale Lawrence. Division of Host Factors. I see that.
Okay, what we've got in Los Angeles, San Francisco, and New York is a number of gay men who've been hit with a variety of opportunistic infections, and really, that's all we know. I've asked Don to join us because for the last 3 years, he's been tracking hepatitis B virus in gay men, and before that worked on the Ebola fever epidemic in Africa. Yeah, thanks for joining us. What we've got to do is hit the phones and spread out, contact the health departments in all the major metropolitan areas as usual, so they can do a hospital-to-hospital search for cases.
Basic shoe leather epidemiology.
That's it. We've got to talk to the patients, talk to the doctors who may have treated those patients, and friends, relatives. No question too stupid or too personal.
Sexual relationships, too.
Lifestyle stuff. Household chemical cleaning, diet,
Could be a bad batch of street drugs.
pets.
Yeah, maybe they all get the same kind of kitty litter.
Don, I'm going to go to New York this afternoon and take a look at this disease. Can you come with me?
Sure.
So, you know, they were casting the net fairly broadly because they really didn't know what they were dealing with. So everything from environmental household cleaners, carcinogens, or potential environmental toxins that may be seen in the house to really thinking about, and again, you know, some of them are coming from a background of infectious disease. People like Harold Jaffe had done a lot of work on sexually transmitted diseases. So some of them are coming back from that background of sexually transmitted agents. But at the point in time, you have to really think relatively broadly with a sort of a totally new outbreak that it may not be an infectious agent. It may actually be, you know, bad drugs, bad street drugs, bad, you know, therapeutic drugs. So one of the issues that became a political issue as well as a misnomer was in the early days, because all the cases were among gay men, the initial name for AIDS was called GRID, gay-related immune deficiency syndrome. But after that, after a while, the CDC received a number of reports of opportunistic infections among men and women who used injection drugs in New York City, recent Haitian immigrants in Miami, and hemophiliacs using factor VIII in newborn children. So suddenly, again, as they went to the health departments, the health department started reporting, yeah, we have cases of pneumocystis, but this is not in a gay man, this is a hemophiliac, and sort of piecing together that it was a broader group of individuals who were affected. And then CDC, as they normally do, as government does very well, forming a task force. We had task forces in Massachusetts and Boston and CDC and throughout the country, reviewing what was going on. The number of cases had risen dramatically since '79. And some of the additional OIs, they were all markers for severe immune deficiency. That was the commonality for all these different indicated diseases. So such disparate diseases as lymphomas and sarcomas, as well as infectious diseases, are really all markers for an immune system that has really totally gone awry and has, in essence, disappeared. So in order to track the epidemic, one has to come up with a name, and it has to come up with a case definition. That's sort of the first thing you need to put together in order to be able to sort of figure out what's going on and track it throughout the country. So here's another clip.
Not approved.
Dr. Kern,
Yeah, what is it?
Jeff called. There's been an outbreak among the Haitian population in Miami.
How many?
4 known dead, but they said that since most of them are hiding from immigration, there could be dozens more. None of them are gay, he said. Just Haitians.
What do you mean, just Haitians?
That's what he said to ask you.
Yeah, okay, thanks. Oh, boy, just Haitians. I don't know. This disease does not make any sense to me. I don't get it. It's completely off the wall. You know, a doctor in the Bronx has just announced that 11 newborn babies have got it. And now Haitians. It's not just a gay disease anymore.
Don, an IV drug user in New York. I just got back. Died from it.
Gay?
A woman.
It's in the blood supply.
I personally don't care if these people were painted by Norman Rockwell. We still have to prove the blood is contaminated. We've got to prove it. What do we know? What do we think? What can we prove?
It is in factor A.
You think?
I know.
Proof.
Well, we can't prove anything is in the blood till we have a test.
We can't develop a test until we find the virus.
Yeah, assuming that it even is a virus.
Finding the virus with the equipment we've got, you got a better chance of winning the Indy 500 with a pair of roller skates.
I am sorry. What about Max Essex? Is he finding anything out?
He can't keep the cells alive long enough to see if there is a virus.
I hear the French have the same problem.
Yeah, so does Gallo.
Does anybody have anything positive?
Well, we may be able to do something about the blood supply, even though we can't find the virus. We know that the people that are getting this disease are almost identical to the group of people that are getting hepatitis B, so we did an experiment. We took the hepatitis B test and took blood samples from 60 gay men who've got it and 60 men who don't. The test was 88% effective in detecting the disease.
Really?
That is fantastic. I mean, if the blood banks can weed out that many people who have the disease before they donate blood.
Exactly. I'd like to remind everyone that these are not regulations. These are not regulations from the CDC. This is a workshop where every agency connected to the blood industry can evaluate information that the CDC has found. And together, we are hoping to be able to arrive at some course of action. One option is to establish guidelines to keep people who are at high risk from donating blood to begin with.
Banning
Our
homosexuals from giving blood won't protect the blood supply. What it will do is stigmatize them. Reminds me of blood banks rejecting donations from blacks for fear of syphilis.
Have you any idea of the civil rights implications of establishing
Civil rights,
such
my
guidelines?
ass. My son's a hemophiliac, and if homosexuals are infecting the blood supply, why not keep them from becoming
What do you
donors?
mean the entire gay community? Then what? Separate drinking fountains? One for gays, one for humans?
Don't start that gay rights crap with me. There are 20,000 hemophiliacs in this country, and GRID has become the second leading cause of death amongst them. We have rights too, and one of them is the right to stay alive.
I know that we're dealing with a very complex and a highly emotional issue, but it would help
I wonder
a lot
how you
if
can
we're all
expect us to be unemotional when at least one person is dying every day from a disease that doesn't even have a name. Now, if the CDC can't bother to come up with a name, at least it should stop the media from calling it GRID. We have enough people hating gays without having the entire stigma of this disease placed on us, especially since it has been shown that this disease is no longer merely gay-related. Now, I make a motion to officially call this disease acquired immune deficiency syndrome, or AIDS.
Questions or discussions on this issue, please?
I second it.
All right, all in favor of Dr. Veller's motion? And opposed? The motion's carried.
So it was interesting, you know, that really there were 20 million transfusions a year in 1983. So having it in the blood supply and not being able to test for it presented a huge public health risk and a huge public health problem. So Don Francis' idea of using hepatitis B, since there's so many people that have both infections, as it turned out, was very, 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 very helpful. On the other hand, there was a real backlash, particularly from the blood industry, about testing, and there were regulations that encouraged people to defer donations to prevent people who, because again, even hepatitis B, it was not a perfect test. You weren't going to be able to identify every single unit that had, now we know, that had HIV in it. So there was a donor deferral program that was put in place. Gay men were discouraged from donating, and other groups were discouraged from donating as well. And you can see how quickly it became such a huge political issue and a social issue as well as a medical public health issue. And it really, in many ways, sort of the pushback and the battle that went on early on was a real problem, really a tragedy, because it really, I think, delayed a lot of public health initiatives, particularly using the hepatitis B test to screen out infected units. And there's a cost associated with this, which, again, added to the cost of actually using blood. You had a question?
I have a friend that works at the Telcris Plasma Donation Center, and she said on their applications that it had said that if any... I have a friend that works at the Telcris Plasma Center, and she said that on their applications it says if you've had sex with, if you're a male and have sex with another male since, I think it's 1987, they kind of discourage you. Do you have a reason why they do that still?
Well, again, so no test is perfect. So there's, the issue around, certainly if you know you have HIV infection or you think you're at high risk of HIV infection, you may be in the midst of seroconversion. In the old days, we used the ELISA test, which took 6 weeks to 3 months to detect antibody. Now viral loads are routinely used, so it's a much more sensitive test. So I guess there's still some residual donor deferral programs that discourage people in the traditional risk groups from donating a plasma and donating units of blood.
Approved.
Dr. Kern,
Yeah, what is it?
Jeff called.
Oh.
There's been an outbreak among the Haitian
Sorry.
population in Miami.
How many?
4 known dead.
I'm going backwards here. So Newsweek had on its cover, once it was announced, KS AIDS was now AIDS being the public health threat of the century. How did it start? Can it be stopped? This is an old slide of mine. You can actually see it was a glass slide, which I dropped numerous times. So the use of the case definition, it was critical to get it out there, providing a uniform definition to facilitate case reporting, and then allowing you to use descriptive statistics basically to track the epidemic, who, what, and where of the epidemic, the person, place, and time of the epidemic, sort of the fundamentals of shoe leather epidemiology, the fundamentals of outbreak investigations.
Do you have many gay friends, Harold?
Not too many, no. 2 doctors I knew at medical school. I still stay in touch with them.
Are they a couple?
Yeah, actually, 15 years at least.
Kiko and I, Kiko's my lover, we've got a wide circle of friends, and most of them are in relationships, or want to be in a relationship.
So what are you saying?
Lots of men go to these bathhouses, but there are tens of thousands of gay men in this city, maybe a couple of 100,000. You know, they're just cops and waiters and teachers and lawyers and ditch diggers and athletes.
Bill, talk a little louder. They can't hear you down the block.
Sorry, I don't mean to lecture. I just don't want you to come away from your tour of the bathhouses thinking that's how all gay men live.
Last night, we lost another one. In less than 3 weeks, this handsome young guy turns into the Elephant Man, which we found out was caused by some rare parasite that only sheep get. So I called a vet to ask what they do when sheep get it. They shoot them.
Good luck. Thanks.
Hi, Bill. Hi, Selma Dritz, Department of Public Health. We're here to inspect the premises.
I'll see if I can find the boss.
Thanks.
Those 2 guys there, they're strangers?
Maybe. Probably.
They just met, and now they're going.
Right.
It's interesting.
Listen to me. Imagine yourself in a place like this. Only it's filled with women. I mean, really beautiful women. I mean, imagine one of those penthouse women, and she wants to go into that little room with you, and there's nothing between you but a little towel. Are you going to tell me that you wouldn't go into that little room, seriously consider dropping that little towel?
Possibly, yeah.
Yeah. I know men who would give up food for it.
Hi, Eddie.
How are you?
Good. Eddie Papazano, Dr. Harold Jaffe from the Centers for Disease Control.
Hi. So what's the problem?
Well, there may be some kind of an epidemic spreading in the gay community, and I'd like to just come in and have a look around.
I'm sorry, that's impossible. We have to protect the confidentiality of our clients.
I know, but Eddie, you know that I speak on behalf of the Gay Liberation Committee, the City Council, the State Assembly. I can tell you without fear of contradiction, you are regarded second only to Abe Lincoln as a citizen who would fight to the death to preserve civil liberties. So let's cut the crap. It's 10 o'clock in the morning, for God's sake. Let us in.
Selma, only for you.
Thank you. Thanks. You're a real mensch, Eddie.
So how many men come here a night?
Hundreds. Every night of the week. Some bathhouses more than 1,000.
What's this?
Poppers. They're a quick, cheap high.
So we had, one of my thesis papers was looking at the role of poppers as an effect modifier in transmission, which it turned out that it was because it's got unique physiologic characteristics in terms of being a vasodilator. We also had in Boston 2 bathhouses, and we were faced with the issue whether or not we felt as a public health imperative to close them down or not. And there was a great deal of debate in Boston and New York and San Francisco about what to do about the bathhouses. They facilitated meeting sexual partners. Some people argued that it made it easy for people to screen for STDs. And in fact, one of our bathhouses in Boston, we had a public health nurse assigned to that bathhouse, and she would do syphilis and gonorrhea testing and treatment. But we, in the end, made a decision to close our 2 bathhouses in Boston because we felt like it was a sexually transmitted disease. At that point, we had more evidence of it as a sexually transmitted disease, and we really felt that we wanted to reduce the possibility of facilitating unsafe sex, which a lot of unsafe sex was going on in these bathhouses. So we have cases, and then the question is, what do you do now? So generally in outbreak investigation, in our epidemiologic toolbox, we do a case control study. That's the analytic study that the CDC and Harold Jaffe undertook. The leading hypothesis for the etiologic agent in 1981 was cytomegalovirus, nitrite inhalants, some kind of immunologic overload because of all the exposures to seminal ejaculate, or some agent X, some new agent that hadn't been described before.
All we know so far is that the immune system stops functioning completely. In all cases? No, but can't prove.
You know, what we have here looks more like a sexually transmitted disease than syphilis does.
Think or prove?
I can't prove that the sun isn't going to turn into a bran muffin next Tuesday. After 20 years of doing this, I know what I know.
That's not what I'm talking about.
Don't say I know it's pure supposition, but it's more than strong enough to justify a definitive study.
I agree with Bill. It's a single infectious agent with a high probability of sexual transmission.
Well, then viral or bacterial?
Well, if you skip think and prove, I'd say viral, but it's only a guess.
Yes, definitely.
Okay, well, let's assume that it is a virus. Now, the question is it one that we already know that has become lethal, or is it some kind of brand new virus that we've never even seen before?
Here's a little stat to chew on. In 7 months, the number of cases jumped from 5 to 152 in 15 states.
7 months?
Yeah, but the spooky part is that so far the mortality rate has been 40%.
40%.
And according to the doctors taking care of these patients, the mortality rate could ultimately turn out to be 100%.
100%.
My God.
All right, let's set up a case control study based on the premise that it's sexually transmitted. Don, I've been talking to the director. We want you to set up a lab here, run it to handle the causative end of the study. If it's a bug, find it. I've just been given approval to head a task force for 3 months, which if this disease is like any of the others, ought to be, plenty of time. And of course, no money, so we're going to have to moonlight this epidemic.
What else is new?
It is I can't guarantee with staff or equipment
Trust him on this.
until I juggle the budget around a little bit.
Okay.
So you can see the situation, sort of the dire situation they were in. So thinking about how to design a case control study, who would be your cases? Yeah?
People who are infected with the varied amount of opportunistic.
So somebody meeting the case definition that had just recently been developed for AIDS and pneumocystis and KS mainly? Because you don't know you can't use the fact that you know it's a virus now. So you got to think who the cases could possibly be. Yeah.
They'd be separating them also into like female to male, homosexual, male to male who uses the drugs with the needle, male who doesn't.
If you have enough cases and enough data, perhaps. I mean, certainly you could try to do that, or you can just sample the whole entire universe of whatever you have that meets that case definition in terms of the cases. What about the controls? Yeah?
Just have a cohort that pretty much matches the cases that you've defined already?
Possibly. So, but if you match on something, you can't look at that variable anymore. So you've made them alike to control for confounding, but you've matched on that variable. So other issues. Okay. Felissa is reminding me that people may not understand a no confounding. It's actually a mixing of exposures, mixing of two variables. Yes?
Maybe just like a group of people who are not sexually active or don't really necessarily do any of those kind of behaviors so that they can compare and then verify if it is a sexually transmitted disease.
In that case, you're sort of matching on the potential exposure. And unfortunately, you would see that basically people who were not sexually active would never be a case. I mean, you really want to sample the controls from people who would have been a case if they became a case. You would have been able to identify them, capture them in your surveillance, and see that is the case. Yeah.
What about prostitutes? Did they ever check them? And then the ones who did have them, and the ones that did have them, and then did they keep track of the prostitutes who were HIV-free, and then later on see if they have gotten it later on?
So this was, again, there were very, very few reports of AIDS in women at this point. Almost 90% of all the initial cases were among men who had sex with men. So women, it was very rarely identified in women. Really, the only women at initial reports, as you saw, were among women who had used intravenous drugs. So women, it turned out that women weren't part of the first case control study. And in their cases, they ended up selecting 39 men who had sex with men with KS, 8 with PCP, and 3 with both. And they really didn't know, just as it's very hard, what's the appropriate control group. So they got multiple control groups. And sometimes you do this in a case control study. These were men who had sex with men who had never had KS and pneumocystis, had never met the case definition. And they were sampled from the clinics, public STD clinics or private clinics providing same services as those providing the MSMs, private controls and private practices. Some of the cases were coming from private clinicians. And then friend controls, a man who had sex with a male friend who had never been a sexual partner. And unfortunately, in each one of these cases, there was a lot of these controls really, as we'll find out, weren't really good controls. And the results of the first case control study that was published in Annals, these are the 2 case control studies, the epidemiologic results and then the laboratory results, found that, yes, it was true that people with pneumocystis and Kaposi's, they were associated with certain aspects of lifestyle, greater number of partners, sex partners per year. They had an immune deficiency of T helpers. But it really didn't tell us very much in terms of what the true etiology was because, well, if you can't isolate the virus, and it's a virus, then you're sort of, what was happening was the controls, many of the controls later on turned out to have HIV. So they were really matching on the outcome. People both the cases and the controls both had HIV. So it was a nice thing to do. It's a logical first step to do in investigating an outbreak. In this particular example, it really didn't yield anything that they didn't already know from the case series. So the leading hypothesis in 1981, sexual transmission in semen, transmission through blood and blood products. Here, So they went on to try to continue to pursue what their hunch was that it was a new sexually transmitted agent.
I don't think so. I mean, I very seldom. Wait a minute. This might help somebody else, right?
Right.
Of course I know him. From the bathhouses. Now, I never had sex with him, but almost everybody I know has or wants to.
Hi, Mary.
Hi. You back in town?
Just for the night. I'm probably nuts, but I'm on my way to New York to try and find a very sexually active French-Canadian airline steward.
Gaetan Dugas? Bill Darrow.
Hello. Nice to meet you.
Nice to meet you. Sit down. Take all the time you need.
Thank you.
Thank you.
Thanks very much for coming in.
Ah, well, I'm very flattered to be asked. Although I have no idea what I'm here to discuss. I wouldn't disturb you if I smoke.
If you need to, go ahead. Mr. Degas, have you had sex with any of these people?
Is that what I'm here for? To talk about my beautiful lovers? And now I am flattered. Although, if you don't mind my saying, I cannot possibly imagine why you'd be interested.
We've been finding substantial evidence to suggest that one of the ways this disease may be transmitted is sexually.
Now, wait a minute. Look, all I have is skin cancer, which is not contagious, and you know it.
No one's accusing you of anything. We just need to know as much as we can.
You know, I adore doctors, but I must say, if it is an epidemic, this gay plague thing, it's your fault for not stopping it. It's not mine.
That's exactly what we're trying to do. And we need everybody's help. So if you could give me the names and addresses of all your lovers and start with the people on this list, please.
My friend, we're talking about thousands of men all over the world whose faces I cannot even remember, and you want names.
Well, as many as you can remember would help.
My book's in my apartment. You call me, huh?
What's the number?
I'll call you.
Listen, help me, don't help me. That's up to you. But don't fuck with me. I'm not playing games here.
Not before 6, and not after 6:30.
Thank you.
And remember something. Whatever it is, if I've got it, someone gave it to me.
All right, this is how it breaks down. This is patient 0, an airline steward from New York, and the starting point of this particular group. Now, these are the 8 with whom he had direct sexual contact. These 4 in New York, these 4 in L.A. This is L.A. 3. He had sex with L.A. 2, this man from Florida, who in turn had sex with this Florida man, 2 from Georgia, 1 from Texas, and so on. In all, 40 cases in 10 cities are verifiably linked to patient 0, which strongly suggests this is a sexually transmitted disease.
That's great. That's absolutely terrific work, Bill. That's great.
Bill, that is the first sign of real proof.
Yep. Good job.
Is there any indication why patient 0 is still alive and others in this cluster died almost immediately?
Well, we just have to assume a variable incubation period.
Yeah.
So here, you know, I'll show the next slide, which so this was published in Annals of Internal Medicine, and this is the slide that he was just showing in the film clip, and you can see patient 0 and the linkages to different people in different parts of the country. Really almost the first 40 cases were all linked to patient 0. Now, we didn't know at the time, and we certainly didn't have any sophisticated mathematical models at the time to be able to simulate this kind of an epidemic in 1984 and 1985. But we knew intuitively that this sexual cluster probably wasn't due to chance. You know, we didn't know how to do a formal statistical test, but anybody looking at this said, well, what are the chances of this happening purely by chance, purely by accident? And there was a really low probability, that all these 40 people would connect sexually in such a way as to represent this kind of a cluster, this kind of an outbreak. And as Dean Burke mentioned, there are probably these kinds of sexual networks going on in 5 or 6 or 7 different parts of the world simultaneously with different clades and different subtypes. But one of the fastest ways that we know now when we model agent and use agent-based models is, these concurrent sexual networks facilitate transmission very quickly of a sexually transmitted agent. And so, they were hitting on the right track. Now, was this definitive proof of a sexually transmitted agent? Well, that needs to move on to, how are we doing on time? We okay? Okay, great. Well, this is the final clip.
Hey, Don. Hey, Dave.
Hey, Dr. Jeffy.
Listen, can I get like a really big chunk of meatloaf with gravy and a couple of pickles?
Absolutely.
Thanks. Hello. What's the matter?
What do we think? What do we know? What can we prove? I'm so sick of that. I mean, the only thing we know for sure is that we don't know anything, which also happens to be the only thing we can prove. We think. Or do we know? Or do we think we know? I don't know what the hell it is. It's
a jelly donut.
Oh, well, thanks, Harold. It's a jelly donut.
You're very welcome. Now you're about a quarter.
Something's gobbling up the T cells. I'm telling you, Max, feline leukemia might be a clue. Really looks infectious to me. Just like your favorite bug, the feline leukemia virus. Look, they both cause cancer, right?
Okay.
They both cause immune suppression. Something's gobbling up those T cells.
Okay.
They both have long incubation periods.
Suspect or no?
But these guys have had swollen lymph nodes, fevers, all sorts of things for years before they get Kaposi sarcoma.
Good. It's hardly scientific proof, but it's good.
All right. What's that hepatitis B? Causes cancer, right?
Right.
Immune suppression, no. Has a long incubation period. Can take up to 30 years to give cancer to the liver.
Right.
Transmitted by sex. No? Yes. It all fits. It fits. The disease that we're looking for looks like a combination between feline leukemia and hepatitis B. So isn't it likely, Max, what we're looking for is some kind of new virus, like the retrovirus that causes feline leukemia?
Possible.
On a épuisé toutes les cultures qui restaient dans les couveuses, dans les glacières. On a essayé l'anti-interféron, utilisé les cellules humaines. Qu'est-ce qui reste?
Rien.
Ouais. Et si dans un deuxième temps, on nourrissait le virus de cellules, pas juste une fois, mais continuellement?
Jean-Claude? On a trouvé quelque chose. Un rétrovirus.
Tout juste.
Found the virus. It's terrific. Just got a call.
I just got a call from Paris. They think they found the AIDS virus. Oh. I need 30 coded samples on a plane to Paris tonight. Can you do that?
So, 30 years later, here we are. Very effective therapy, very effective treatments, but still no vaccine. And in fact, one of our major frustrations is the inability to develop a vaccine against a retrovirus, or actually we have a vaccine against fetal leukemia, which is a retrovirus, but our inability to develop an effective vaccine has been a real source of frustration. Within a very short period of time, though, people were able to use and develop an antibody test, which was very effective at screening the blood supply, and very effective at folks identifying if they were HIV infected or not. And also at the same time, there was an announcement, an unfortunate announcement, that with the discovery of the virus, that a vaccine would be only